Good morning, everybody. We're just going to wait a couple more minutes. We have one member who's in transit but is caught in traffic. Okay, I think we're good to go. Good morning, everybody. I'm going to go ahead and call to order the SEMSC meeting of October 12th. We'll go ahead and get started. We'll start with the salute to the flag. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right, let's go ahead and do roll call.
Bill Emlin.
Here.
John Jansen.
Here.
Joshua Shadwick.
Here.
Caesar Javaharian.
Here.
Greg Folsom. Thea Gibney.
Here.
David Piscinati. Here. Okay, we have a quorum.
All right, thank you. All right, so first item on the agenda is items from the public. So this would be a time for folks who want to speak to the committee here that are have an item they want to bring forward that's not on our agenda. So does anybody have anything like that they want to speak with us about? Okay, then we'll go on to the next item, which is approval of minutes. We have two sets of minutes this morning we're going to be reviewing. The first one is July 13th, 2023. Any discussion? If not, then we'll go ahead and take a motion on the minutes.
I'll move. Second.
Okay, all in favor?
Aye.
Aye. Opposed? Okay. All right, then I'll move on to the August 28th minutes. Once again, any discussion on those? Okay, motion?
I'll move.
We have a second?
Second.
All right, all in favor? Aye.
Aye.
All right, that was quick. We got through that. And then approval of the agenda. Members of the committee, anybody have any changes, or we'll move forward with the agenda as proposed? Do I have a motion?
I'll move it.
I'll second.
Okay. All in favor? Aye.
Aye.
Okay. Then we will move on to reports, and we'll start with the SEMSC Medical Director's report.
Excellent. Thank you. Good morning. Apologize for being late. Both my kids are sick, so it's their fault as usual. From the kind of medical director's perspective, I think we reported on this last time, but we're really revamping a lot of our protocols that we currently have in place. As you might know, a lot of our BLS, specifically our protocols, are very outdated. And what we've been doing is creating a new format where they're organized by chief complaint, and then the BLS and ALS protocols are all in one document and one common protocol, given that the ALS interventions are a natural extension of the BLS interventions. So we've just been continuing to move forward in this. So in the past quarter, we've had 5 new protocols under, just for sake of listing them, B1 for behavioral emergencies, B2 for abuse, C1 for shock, C10 for chest pain, and C14 for STEMI. Those are all new protocols that were revised and enacted, and then the relevant BLS protocols that mapped to those chief complaints were discontinued. I believe our website still has to be updated, but those protocols are live. We currently have 2 protocols out for comment. One is C3 on pulseless arrest, and this actually combines several protocols that we had in the past that divided out the etiology of pulseless arrest, so we've tried to consolidate some of that. So this is replacing BLS C3, as well as 3 ALS protocols, C3, C4, and C12. So we're hoping to consolidate and make things simpler in that way. We have one new protocol that we have put forward on sepsis or suspected sepsis, M10. The reason for that is because sepsis obviously causes a lot of morbidity and mortality in our community. And we found that early recognition of sepsis can lead to decreased morbidity. And so we've put together a new protocol that's essentially trying to recognize sepsis in a pre-hospital standpoint and essentially encouraging more aggressive fluid resuscitation, earlier in the course of illness, and allowing for vasoactive drugs to be given to support blood pressure, during that time, and making it a little bit more explicit, in protocol. So that's currently out for comment as well. So we'll move on to policies. 2 policies were enacted in the last quarter. The first one is 5700, which basically updated the stock for the required stock for non-transport providers to reflect, again, our protocols, as well, and the expanded scope as we had discussed in prior meetings. And then policy 6612, which is, and we've discussed this before as well, but it went into practice this last quarter, which is the one that allows ALS providers to utilize the cardiac monitor as an assessment tool. We discussed this before, especially when we were speaking about the relative distinction of ALS versus BLS level of care that's being provided. And prior to this, essentially, once a medic put a monitor on the patient, it became an ALS call, and we continued that kind of throughout. And what we've allowed for now is, based on a lot of work, Adeline had done looking at what were the interventions that these patients received. We've basically allowed for a medic to use the monitor to just obtain more data on the patient's acuity of illness, but then can still run that as a BLS call once they get that information. If any other ALS interventions, IV or EKG, are done, then it stays ALS. But they're allowed to put the patient on the monitor to just obtain more data, and then, if appropriate, that patient can become a BLS level of care, if that makes sense. And then lastly, we had, I think, mentioned also last time, we have one EMT discipline case pending. This is for a Solano County medic, but the incident occurred in Sacramento County. And it's it's under criminal investigation, I think, at this point, and so because of what happened in the line of duty. So until that process finishes, then we'll move forward with our actions, regarding their certification and license. But until the court cases are completed, we usually don't move forward with from a certification standpoint perspective. And that's it, I think, for the medical reports. I'm happy to take any question.
Okay, any questions? All right, then let's move on to the EMS administrative report. Ben?
All right, thank you, Bill. Good morning. 2 quick updates for our EMS team. We have just acquired a new deputy health officer, Dr. Cameron Kaiser, right there, the gentleman raising his hand. He comes from San Diego County. He is definitely taken involvement here and trying to learn our EMS system, so he'll be here and hopefully throughout the months playing a larger role with our SEMSC. The other update is that Karen Ariola will be going on maternity leave here, so if next meeting is not as smooth as it has been, I would like to just say that it's because she will not be here. So she'll be greatly missed, but we're very happy for her family on welcoming her child here soon. Now off to the response times. This is going to be reporting for quarter 4, April through June. Benicia Fire Department is at 95.1. Dixon Fire Department is at 99.6. Fairfield Fire is at 94.6. Vallejo, 94.1. And I'm happy to report now that Suisun City is now in this PPP contract and providing data, and they're at 96.1%. So this is great news that we've added another city. On to our EOA, our medic ambulance provider, is 99.4. And if any other questions, I'm going to save a lot of the time for the team because we've got a lot of data and some presentations today.
That's a good quick question. Just a quick question. Not that we're competitive or anything, but when you say Dixon's at 99.6, is that just the city of Dixon, or is that they're covering their district as well?
Not competitive at all, Chadwick. But it is just their response area to their city. So.
Okay, any other questions? All right, then we'll go on to the medic ambulance operators report. right, thank you. Any questions? Okay, then we will go on to our quarterly activity report, starting with EMS general data.
No one's as loud as Jimmy.
You ready to go? Yep. Alan, maybe we take a quick break and see if we can get this thing hooked up.
Good morning. My name is Adeline Ansari, Health Education Specialist with Solana EMS, and today I will be presenting on general EMS data for the reporting period of April 1st through end of June 2023. First, we are looking at our 911 call volume. Here you can see our 911 call volume for the past year being breakdown per quarter. The data in purple shows the total 911 requests we received. The data in blue shows how many we had actually made a patient contact with. And the data in green shows that out of those patients that we made the patient contact with, how many it got transported from the scene to the hospital. Next, we're looking at city of incidents for reporting period of April through June. So we had a total of 9,309 911 request that was initiated in our county and ended up being transported from scene to Solano receiving facilities. So this number does not include those 911s that went out of county. Above the name of each city, you can see two bars. The bar in blue shows the actual 911 request each city received, and just to have a fair comparison between each city, we had a yellow bar calculating the incidence rate per 100,000 population. Just looking at the blue bar shows that Vallejo and Fairfield had the highest 911 request, which makes sense because, they have the highest population in our county. But when you're looking into consider their population size, when you look at the 911 request, you can see that Rio Vista actually has the highest 911 request considering their population size. And this is nice to see that when we have resources to be distributed to our cities for EMS or hospitals, then we know which city might have the most need. Next, we're looking at response priority and transport priority. So the graph to the left shows response priority. It shows that for the reporting period of April through June, from dispatch to the scene, 93% of the time, we responded as code 3, which means light and sirens, and 7% of the times we responded as code 2, which is no light and sirens. And the graph to the right for transport priority, it shows that from the scene to the hospital, we took the patient was transported 7% of the time under code 3, and 93% of the time under code 2. Next, we're looking at level of treatment received. So we were interested while we were transporting the patient from the scene to the hospital, what type of prevention they received, if it was advanced life support treatment, which we call it ALS, or basic life support treatment, which we call it BLS. As you can see, 66% of the patient received ALS treatment while they were transported to the hospital, and 34% received BLS treatment. The chart below the graph shows the breakdown of our code 2 for ALS and BLS. So we see that 59% of the patient received advanced life support treatment while it was taken to the hospital as code 2. Just, for our better understanding why we have 59% ALS code 2, as we discussed in the past, we dive deeper into our data and just to see what type of ALS intervention was provided to the patient. And you can see 17% of the patient received cardiac monitor as the only ALS treatment. And again, this is for reporting period of April through June. 39% of the patient received saline lock and cardiac monitor as the only 2 ALS treatment, and 44% received all other ALS treatment performed. As Dr. Shetty mentioned, we updated our protocols for cardiac monitor. So now we have an option of putting cardiac monitor on and then if it's not maintained on the patient during the whole transport, then we could consider that transport that the patient received the BLS treatment if no other ALS treatment was provided. So hopefully, I would say by end of this year or beginning of next year, we will see a change in our number of percentages for cardiac monitor, and then hopefully we could see if our ALS percentages stayed the same or went down. I know there was a question last time that how are we going to monitor the data for the cardiac monitor that we changed our protocol. And, as it was discussed on our patient care report, which we call it PCR, there's a section that, whoever fills out the PCR, they have to say if this call was a code 2 or code 3, it was ALS or BLS, and what type of treatment they received. So this is how I was able to get that 17%. But just to make the cardiac monitor data collection more efficient and easier, we decided to add a new custom element data on our ePCR. Before for me to explain how we did that and what question we added, I have to explain to you National Emergency Medical Information System, which is called NEMSIS. So what is NEMSIS? NEMSIS is a national system used to collect, store, share EMS data from U.S. states and territories. NEMSIS develops, maintain national standards for how patient care information resulting from pre-hospital EMS activation is documented. So NEMSIS had, they went through different versions. Right now, currently, we are using the 3.4, but as in the whole nation, we are transferring to the 3.5 NEMSIS. And our county, we are within 2 weeks, we're going to transfer to 3.5 NEMSIS. During this transitioning from 3.4 to 3.5, it gives us a chance as a LEMSA to add any data element that we want, any custom data element we want on our PCR. And then also if there was any data element that Nation or NEMSIS wanted to be considered as recommended or required, we could change that to make it mandatory for us in our county. So these are the list of the data elements that we are making it mandatory in our county. The good thing is our transport agencies, the main two ones, which is medic ambulance and VACAble fire, internally they were already collecting this data as a mandatory internally. So it was good that, we had a chance to also make it mandatory, like documented. So this way all of our transport agencies is going to follow the same standard for reporting data to us. But I want for you to look at the vitals that is in purple. So that's the place that we're putting the custom data element there. So there's going to be a question on our EPCR. It's going to ask if the cardiac monitor was used continuously, yes or no. And that's how we're going to be able to monitor our data for cardiac monitor. So hopefully next time when I'm presenting, I will have updated numbers for our cardiac monitor and ALS protocols. Next, we're looking at ambulance patient offload time, also known as APOD. So in our county, the APOD standard is 20 minutes. That's, you see the dotted line there in red. That marks the 20 minutes. And there is a potential future California benchmark for APOD, which is at 30 minutes, which you can see the dotted line in green. Looking at our APOD for the last quarter from April through June, you can see that we were standing at 21 minutes and 48 seconds. And comparing to the quarter previous to that, which was 23 minutes and 7 seconds, we see improvement. So I want to give a shout out to our hospitals and transport agencies for doing an amazing job. As you can see, for our APOD, we are a little over that 20 minutes standard for our county, but we are below the 30 minutes potential California benchmark. Next, we're looking at specialty care programs. We have 4 specialty care programs in our county, and you can see the name of the designated hospital for each program. The designated hospital has not changed since last presented. So next, we are looking at quality assurance and performance improvement. So each quarter, we meet with all of our hospital providers and pre-hospital providers. We call it EMS quarterly meeting, and at each meeting we are presenting on a selected specialty care program data that we want to go over. The purpose of those meetings to see if the data flow is happening and is easy and is happening between our hospitals and pre-hospitals. And then also this type of meetings is going to give us the chance to see if any protocols needs to be updated. Today, our team is going to present in the afternoon on EDAP and trauma at our EMS quarterly. Just to give you a better understanding what we're presenting at our EMS quarterly, I will present the trauma data to you right now, but I'm not going to present EDAP, to be considered as everyone's time. But if interested, please let us know. Next time, I can present the EDAP data as well. So for our trauma data, the reporting period is going to be from January through June 2023. And the data I will be showing you is a combined data of our 2 trauma centers that we have in our county, Kaiser VACAble being level 2 and North Bay being a level 3 trauma center. Here you can see a trauma case volume for over a year, breakdown by each quarter. This type of trend analysis is going to give us a better understanding if we had a dramatic change in our trauma cases in our county. Next, we are looking at demographics. So again, for reporting period of January through June, we had total number of 660 trauma cases in our county, which mostly being male and mostly being 65 years and older. Next, we're looking at mechanisms of injury. So fall with mechanism of injury has the highest percentages as a mechanism of injury for trauma in our county. And bicycle and blunt assault being the lowest. And I think there's some formatting issues because we do have a percentages also there, so maybe you can see it on your printed PowerPoint. But bicycle and blunt assault has the least as a mechanism of injury in our county. Next, looking at the post-ED disposition, most patients went to floor or step down after being released from ED, and we have the least cases for least percentages for the expired cases. Next, we're looking at hospital discharge disposition. As you can see, most of our trauma cases went home, and we had around 2% that was transferred out to receive the higher level of care, and we had around 2% or 13 cases that expired. As for transfers, we had total number of 83 interfacility transfers. 38 of those cases were mainly walk-ins to the non-trauma patients, and we had a couple cases that it was an EMS scene run to the non-trauma cases because the patient was unstable. We had 20 cases was out-of-county interfacility transfer, meaning that those patients, they were already in the hospital out of our county and got transported, to our county. So this number does not include those cases that they were trauma cases that was transported to us from scene of out of county to us. So this is only showing the interfacility between the two hospitals. And we had 25 trauma cases for being transferred because of the insurance coverage. We had total number of 16 transfers to the higher level of care. 10 cases went to UC Davis, 5 cases went to Children's Hospital of Oakland, and 1 case went to St. Francis because UC Davis was at capacity. So this concludes my part of the presentation. At this time, I will take it to Scott Wagner, our new EMS coordinator, to go
Real
over
quick, Adeline, the slide before, if you want to go back, the slide that we have, I think there was a last-minute update because the numbers are off.
This is the updated number.
Okay, so this is the updated. Okay.
Yes. I'm glad you mentioned that because I want to give a shout out to our trauma centers here, North Bay and Kaiser. I have a lot of questions on traumas, and then usually there's a last minute checking the numbers, I'm asking them questions, so they explain cases to me. So, we had meetings, and this is the updated numbers. Thank you.
No, thank you.
Hello, everybody. My name is Scott Wagner. I'm the newly hired EMS coordinator for Solano County EMS. I'm going to tell you about some of our current projects and some things we have upcoming. For BFAST outreach, BFAST is a stroke assessment that stands for Balance, Eyes, Face, Arms, Speech, and Time. We found a vendor that will provide free BFAST stroke symptom educational materials, and we're placed an order for those for magnets, brochures, and wallet cards. They'll be here soon. We're going to distribute those throughout the county to improve stroke symptom awareness. For our BLS and ALS protocol update, we're currently combining our BLS and ALS protocols into one simplified flowchart, like we talked about a little bit earlier. During this process, we're reviewing each of our protocols, making updates as needed. We've been working with some other EMS agencies and reviewing current EMS research to verify that our protocols are meeting or exceeding the standard of care in California. EMS for Children Technical Advisory Committee and CQI Committee. I'm passionate about improving pediatric care whenever I can. To help achieve that in Solano, I've become an active member of the California EMS for Children Technical Advisory Committee. This group is medical professionals throughout California, from pediatric physicians in the emergency department to nurses, California EMSA representatives, and local EMSA coordinators. The goal of this committee is to discuss pediatric emergency care throughout the state and provide expert advice on how to improve outcomes in the future. We're also actively participating in the California Local EMSA Quality Improvement Committee. This group provides advice and consultation to the Emergency Medical Services Administrators Association of California, and with the goal of improving patient care throughout EMS systems in California. And lastly, Stop the Bleed training and outreach. Stop the Bleed is a program developed by the American College of Surgeons to teach simple and effective bleeding control techniques to first responders, hospital providers, and members of the general public. We're working with stakeholders to improve our existing training network and to spread this program throughout Solano. Our plan is to increase the number of trainers in our healthcare system so they can teach the public these life-saving techniques. That concludes our presentation. We're here for any questions, and thank you guys for your time.
Not seeing any questions, so we'll go on to the next presentation. Do we have more?
I think we're gonna move to the regular calendar.
Okay, then we'll go on to regular calendar. As we get started on that, we have two regular calendar.
Sorry, items from the public.
I'm going to jump to that here. So we have two regular calendar items today. And basically, before we get to that, we have a time for folks who want to speak on those to speak. So this is your opportunity for speaking on either regular calendar items. Does anybody from the public want to speak?
Good morning. Excuse me. Good morning. Thank you for the time. My name is Bill Bullard. I'm the president of Healthcare Strategists, and I just wanted to introduce myself to you. We haven't had a chance to actually formally meet. I live about an hour away, so it's an easy drive for me to come on over. Our team has between 35 and 50 years of experience in EMS consulting, and we'd be happy to serve the county. We're here if there are any questions today, and that's all I wanted to say. So thank you very much.
All right, thank you. Anybody else from the audience want to speak on these items? If not, we'll go ahead and move on to the item 8A. And Ben, do you want to introduce?
Yes, so we were asked by the board for some further questions. Those were provided in your packet. So we've got the original set of questions, phase 1, and phase 2 for the additional questions that we asked the 3 vendors that are to be selected. I'm going to ask Karen to almost do a little roll call between the board members. You're going to tell her your first, your second, and your third choice, and then I'll have Bill move motion, and then move forward to the vendor that has been selected.
Okay, so for the voting, Bill Emlyn, do you have a first choice?
I'm going to defer until the end.
John Jensen?
I'm going to defer till the end. No. Yes, my first choice was the healthcare strategist. Second, my notes on is the endpoint EMS.
Okay, noted. Endpoint EMS, and then filler security as third. Okay, and Joshua Shadwick?
Yeah, number 1, filler. Number 2, healthcare strategist. Number 3, endpoint.
Caesar Dabaharian?
For me, it's healthcare strategist, filler, and then endpoint.
Gia Gibney?
Number 1 is healthcare strategist. Number 2 is endpoint. And I don't have a third. I wouldn't support the selection of filler.
Okay. And David Piscinati?
Number 1, healthcare strategist. Number 2, endpoint, which leaves filler as number 3.
And back to you, Bill.
Okay, healthcare strategists and endpoint.
Okay. So the first choice per vote is healthcare strategist. Second choice per vote is endpoint EMS. And the third choice will be filler.
Okay, so at this point, do we need a motion then to?
Yes.
So do we have a motion?
So moved.
I'll second.
All in favor?
Aye.
Aye.
All right. Now to the second regular calendar item will be review and adopt a resolution that rescinds a portion of the resolution 11-001 and approves requiring operators of emergency ambulances to obtain authorization to operate in Solano County. I do have Keith Erickson here, my EMS coordinator, has worked with County Council on updating this for any questions from the board.
Sure, so why?
Well, first one, it was conceived back in 2010 and has not been revised since then. And one of the main issues of it was the set dollar amount for the permits and inspection fees for the units. So every time we'd want to raise fees, we'd have to come to a vote from the board to increase fees every time. So we took that out and we put in a clause saying whatever the fee is set forth in policy 3000 EMS fees. So it would not take up the board's time to vote on a fee increase every single time. And our fees are bargain basement at best right now for BLS and CCT fees compared to the rest of the area. We also had an investigation not too long ago that, in conjunction with Julie, we found a lot of loopholes in our appeals process that needed to be tightened up, especially when a operator does not show up for the hearing, which we had a problem with that for the last time, and because they called off on the day of the hearing. So we made it a little bit more stringent, and they can ask for one continuation only. And then after that, if they don't show up, there is no appeal process for them. We also raised the fees for the penalties also, which for very small penalties, like for the first infraction, it was $1,500. $1,500 for any provider, that's nothing. They'll write the check every day for that. So we put it more, we raised all the fees for penalties also.
Yeah, is this just for inter-facility, or is this 911 response?
Correct, that, not non-exclusive providers only. Fire would not have anything to do with it.
Is there any situation where you would need it in an emergency? In other words, like if all the medics units were out, and I guess Medic and Vacaville are the only ones right now, is that correct?
Correct.
Or is there a situation where you, by doing this, you'd be excluding some sort of serious emergency where there's nobody to transport?
Yeah, correct. That'd be a mutual aid thing, and Medic would request that.
So that
or to go
they
through
would still be able to come into the county in that situation?
Correct, or to go through, if it's a big enough incident, go through the Mohawk.
What's the process for the review of applications and the criteria for approval or denial of those applications?
That's spelled out in policy 5510, the ambulance permit policy. There's an initial process where they review the financial structure of the company, what units are going to be involved, all their contacts, review of their insurance certificate, and review of their CHP inspections also. And then they renew every year. And then CCT is every 2 years.
And so what would be the criteria for approval or denial based on that?
It would not affect the permit process whatsoever. It would just affect the renewal fees and inspection fees.
So is that the same as saying that anyone who applies would be approved?
No, we'd have to review all their documentation first. To make sure that the company is solvent, first of all, to make sure that they have the correct staff in place, such as medical directors, clinical coordinators, that sort of thing. Make sure all their units are up to standard of what we have put forth in our unit checkoff, to make sure they can even operate here, and also to make sure the vehicles also are up to CHP code.
Thank you.
No other questions? All right, do we have a motion on the resolution?
I'll move it.
Second?
Okay, all in favor?
Aye.
Aye. Okay. We've gotten through our regular calendar items, and we are now to board member comments. I have no further comments. Anybody on the board have comments or updates for the group? No? Wow, well, we're moving pretty good today. So, all right, then at that point, we will go ahead and adjourn the meeting of October 12th. Thank you, everybody. Have a great day.